Well, thank you all for attending today. I'm looking forward to telling you about topical therapy for melanoma and other skin cancers. And topical therapy is not something we think about so much when we talk about melanoma. As a dermatologist, dermato-oncologist, I think about it a lot for a lot of skin cancers. So let's just get into it here and learn about topical therapy for melanoma and other skin cancers. So can we use topical treatments for melanoma and other skin cancers? That's a big question. Let's see if we can. Let's see. So these are some of the topical agents used to treat skin cancer. We have Imiquimod is one we're going to talk about quite a bit today in detail. It's FDA approved for treating superficial basal cell carcinoma. And it's actually a good first-line treatment for superficial type of basal cell carcinoma. There are about 5 different types. I think Dr. Yashi did a really good introduction to skin cancers. And so that kind of made my job easier. But for the superficial type, it's FDA approved. It's good. We also use it for actinic keratoses. And we're going to see that it can be used for melanoma, but it's very specific uses and so forth for that. 5-fluorouracil. And Imiquimod is also brand named Aldara. This one brand name. 5-fluorouracil is brand name Efidex. I'm mentioning that because many of you as patients might be more familiar with the brand names. I'm going to talk about off-label treatments during this talk, and I have no conflict of interest in regard to this talk. It's FDA approved also for treating superficial basal cell carcinoma and actinic keratoses. These are the pre-cancers. They go on to form squamous cell if they don't go on to form melanoma. Bleomycin, not commonly used. We use it for fairly rare kind of skin cancer called extramammary paget disease. These are usually very superficial skin cancers of the groin area. And PDT, maybe some of you in this room have had PDT. It's a blue light therapy, we call it. So basically you paint on this chemical that's photoactive, and it's preferentially taken up by cancer cells or precancers. You give it time for the cells to take it up, and then you shine blue light on it. That activates the chemical and kills the cancer cells or precancer cells. We use that mainly for treating the precancers, but it's also used for treating these other kinds of skin cancers. DPCP. Now that's basically a contact allergen. It actually stimulates the immune system. We're going to talk about that a bit more too. But it's not approved for treating melanoma, but we're going to talk about it being used for that. Liquid nitrogen. Well, that's a topical treatment. I'm sure many of you in this room have had liquid nitrogen. The dermatologist comes in and sprays these precancers, these little rough scaly spots on your skin. And that's the most common way to treat that. It's not acting chemically, it's acting physically. That liquid nitrogen is cold. It's minus 195 degrees centigrade. That's minus like 300 plus degrees Fahrenheit. So it's really cold. And you just spray it on there, it immediately freezes the cells that are growing abnormally and gets rid of them. That's a really great treatment. It's, like I say, the number one treatment for precancers. It can also be used to treat basal cell and squamous cell, but we usually like to rather cut those out or treat them otherwise. It's occasionally used to treat melanoma in situ. It's kind of last line, I would say, for melanoma in situ because it doesn't work that well. But if you basically have a very big cancer and you can't use surgery, you can't use radiation, you can't use Imiquimod, well, then you can consider treating it with liquid nitrogen. I've seen it done before, and it can be helpful, but it's, like I said, considered the last line. So let's talk a little bit more about Imiquimod or Aldara. It's a topical cream. We're talking about creams basically that you're putting on the skin today. And it's been studied to treat melanoma in situ. And we're going to talk, what is melanoma in situ exactly? Some of you know, certainly the physicians in here know, but we'll kind of go into that a little bit. So let's talk about Imiquimod to treat melanoma. So it is a cream that's applied. It's FDA approved to treat superficial basal cell, like we said, and actinic keratoses and warts. It's also FDA approved to treat warts of the skin because it stimulates the immune system to recognize all these things as something that doesn't belong on the skin and to get rid of that thing that's not belonging there. It's not FDA approved to treat any type of melanoma of the skin. Well, let's talk about it though to treat melanoma of the skin. And this is a specific type we can use it for is melanoma in situ. So studies have shown that a complete response rate from about 65 to 85% for treatment of melanoma in situ with Imiquimod. Well, for melanoma, which we consider to be a very serious kind of cancer, That's not very good, 65 to 85%. So we don't really want to use it as primary therapy. Primary therapy is the therapy you're going to go to first. So we don't want to do that. It's not on a par with surgical excision or superficial radiation therapy for treating melanoma in situ. But if the patient's not a candidate for surgical excision or radiation, then you can consider it, as third line therapy. And certainly it can be very useful in those cases because for various reasons, a person might not be a candidate for surgery or radiation. It's not effective for treating invasive melanoma of the skin. So only in situ, and like I say, in a second, we're going to talk about in situ a little bit more in detail. Cure rate is just not high enough for invasive melanoma of the skin. So we're only talking about treating it in situ. This is a cartoon. It's not a great cartoon, but it shows the different stages of melanoma. This first one is in situ here at stage 0. We call it stage 0. And so on this cartoon, you have this first pink layer of the skin is the epidermis. Dr. Ye showed you much better pictures of the skin in side view here. Actually, the epidermis is 2 paper sheets thick about on average in the skin. And the dermis is actually, this is even simplified, it's about 10 times as thick as the epidermis. So the epidermis is very thin. And this cartoon is not that great because actually it shows it just sitting on the surface, but actually the melanoma in situ basically is just right at the base of the epidermis. It kind of goes along here. And Dr. Ye did show you pictures of melanocytes sitting there at the base of the epidermis. And so in situ is great. When we see in situ melanoma, we consider it a success story because we know if we cut it out at that stage, it hasn't had a chance to get down here. You can see down here in the dermis, you have blood vessels and you have lymphatics. The blue is lymphatic. And when the melanoma gets down here, it comes in contact with those. Well, melanoma cells can break off and travel through the blood or the lymph and go to the lymph nodes or other organs of the body, and that's bad news. Next is we have stage 1, which is invasive. So it's kind of gone a little bit past the epidermis here, just at the base. And so that's invasive melanoma. And again, we would not use topical therapies for invasive melanoma. Here it's stage 2. It's gone even deeper. And it's like 1 to 4 millimeters is going to be stage 2. Stage 3 is where it's gone so deep, it's actually gone into the lymph nodes. This is lymphatic. So you can see it's kind of invaded the lymphatics, and that's going to travel to the lymph nodes. So that's when surgical oncology and the medical oncology come into play. And stage 4 is where it's basically gone through the blood into other organs like the liver, lungs, and brain, and so forth. But we're interested in situ, which is basically up here. So let's look at the next slide. And this is not a pretty picture as Dr. Ye showed because she's a dermatopathologist and she can take her own pictures. But this shows the epidermis, and the dermis is down here, this paler area down here. But this upper part is the higher magnification of the epidermis. And you can see each one of these are individual skin cells. And again, the total distance from this to this is only about 2 paper sheets. So this is highly magnified. But this shows melanoma in situ. And all these pigment cells down here, there should not be that many. When she showed the melanocytes, you didn't see them like this. This shows you why melanomas are black, because they produce all this pigment, and you see all this. They're just sitting down here very disorganized. They kind of move up into the epidermis, further up, all the way up to the top of the epidermis. So this is melanoma in situ, and it hasn't gone down past the epidermis. It hasn't been able to get to the blood vessels or lymphatics. So like I say, if we can cut it out and get it at this stage, we consider it success. Okay, this gentleman has this, let's look at it clinically. This is melanoma in situ on the nose. You might think, Jesus, it just looks like a sunspot, but it has some other features that dermatologists would definitely say, we need to biopsy this, because it's got some very dark areas, black areas, essentially. And the pigment is not very symmetrically organized. It's a big lesion, and he doesn't have anything like this elsewhere on his face. So this is a sun-caused type of melanoma called lentigo maligna. And it definitely is what we're going to talk about as far as could be amenable to partially treating with topical therapy. Okay, this is another lesion here. This is an 83-year-old woman who was referred to me for something on the ear. The thing on the ear was just a benign seborrheic keratosis. So the physician who referred it thought maybe it could be melanoma, but it wasn't. But then on doing the exam, I saw this thing on her wrist, and again, it kind of stands out. It's a little darker than all the other stuff on her skin, a little bit bigger. And when we look at it closely, different views of it, It has some features which you can't see that well here, but with the dermatoscope that we use in clinic, it's got some dots and globules in there that make us concerned for melanoma. And so I biopsied it. And indeed, it was melanoma. So this one's a little bit invasive. It's 0.3 millimeters. So we wouldn't treat it with a topical therapy first up. So we want to cut it out. This is my planned excision here. And for melanoma, you want to take a good margin. So this is a 1 centimeter margin. It's invasive. That would be standard. Cut this out. And this is my planned excision. So I'd cut it out like this with the 1 centimeter margin. And then we cut up here and cut down there. And then this skin is all going to be undermined. We're going to move it towards the center. We're going to move this towards the center to close this big hole we make. And you can see this is on the wrist, but if it was on your face by your eye, that's going to be problematic, right? I mean, how are you going to cut that out with that big margin, for one thing? And two, how are you going to close it? You have all those big lines you're going to have to move the skin around to do. So that makes it hard. And that's, so we'd like to take a smaller margin on something like this. We're going to talk about what techniques that can allow us to take a smaller margin so we don't have to make such a big hole in a person, particularly on the face. It's okay here because the skin is lax enough that we can do it. Now, next slide, I'm going to show a picture of where I cut it out. So if you're a kind of person who doesn't like to look at wounds, you maybe not look at the next slide, a couple slides, 2 slides. Anyway, this is the wound that I made when I cut it out. And you say, Dr. Linden, that's a lot bigger than this. Well, actually, I did cut it out the size I showed there. But when you cut out something, the skin just tension will just kind of pull it open. It kind of gapes. So that's how the skin is gaping there. Here's a close-up, a lot of neat anatomy down there. But the good news about when we cut out melanomas, if they're thin like that, all you do is cut out skin and fat, and you leave everything intact beneath. So there's a lot of important structures in your wrist right there that you don't want to damage, and we didn't. So I did close it. Like I said, I undermined it, cut up all the skin up here, undermined it, all down there, pushed the skin to close the hole that way, that skin to close the hole that way. It's called an O to S closure. Here it is 2 weeks after suture removal. Healing like a champ. Here it is again. Now there's a picture of that 6 months after excision repair. So that melanoma never came back. So that's how we like to treat melanoma. Cut it out. That's the number one treatment for it. Particularly the thinner melanomas, a chance to cut is a chance to cure, we like to say. And that's definitely the case for melanoma. Okay, but this again is on the face. And this kind of shows, and this is also a lentigo malignant type of melanoma. This is sun-caused melanoma. Dr. Ye said it's important to protect yourself from the sun because you don't want to get these sun-caused melanomas. Anyway, this one shows another kind of some problematic features here. So here we have the melanoma, but you can see it's really hard to distinguish. Well, where's the margin on this? Like it's kind of dribbling out with pigment over here. And it's kind of dribbling the pigment out here. And you have pigment up here, here, over here. So where are you going to cut your margins, even if you take a narrow margin? So this can be very difficult to determine the margins of where to cut. You could treat this with radiation. Like I say, we'd prefer cutting. It's got a higher cure rate, but you could treat it with radiation. That'd be a quite reasonable option to treat this. But you have to choose some margin, and you could either just cut it out and see if you got it all out, or you can do Mohs surgery. Some of you in this room, I'm sure, have had Mohs surgery. I know you've had Mohs surgery, some of you, because some of you are my patients. Anyway, that's a kind of where you look at it in the microscope right then to see if you got it all out. And that's a good technique. It's really hard for melanoma because it's hard to read melanoma under frozen sections. Dr. Ye was saying how hard it can be just even with permanent sections, and you're an expert like her. Well, if I'm a derm surgeon, I'm trying to read it, it's also very hard. So we want something to help us out. And that's where maybe topical therapy can help us out. And we'll see about that in a minute. And here's another lentigo malignant type of melanoma in situ. Again, this is huge, and it kind of dribbles out down here. And so you have to figure out, okay, what margin am I going to take? And am I going to get it all? And you could cut this out. You can have to move the neck skin all the way up, like that. It'd have to be done in the OR for sure. But it could be done, but also radiation would be a good treatment for this type of melanoma in situ. So in situ is just an upper layer of the skin, and it will respond to radiation. We don't like to treat invasive melanoma with radiation at all because, again, invasive is just not quite there. When it's sitting on the surface of the skin, it's pretty amenable to radiation. When it's only in the layer that's 2 paper sheets thick. Now, we talked about lentigo malignant, the sun-caused melanoma. This is another type of melanoma that can be in situ, which means it's in the upper layer of the skin. But the superficial spreading type is more well-defined as far as borders. So if this was on your back, you could feel confident if I took this out with 5 mm margins or 1 centimeter margins, which would be standard for melanoma, that we would highly likely to achieve clearance. So we wouldn't use topical therapy in something that this is well defined, and we could take a good margin on and be very confident in our margins. So we're still getting to treating it with topical. We're getting there. So anyway, by now you're all probably thinking, geez, I've got a bunch of melanomas on my skin. But you don't. So not everything that's pigmented is melanoma. This shows just a sunspot, basically a solar lentigo, another sunspot. These are benign. We see that most people have these. And these are seborrheic keratoses. Again, dermatologists looking at this would not look twice at these. And you start getting these in middle age, almost everyone starts getting them, and you get just more as time goes by. As decades go by, the more you get. So not everything is pigmented melanoma. So now let's get back to actually talking about treating these with topical therapies. So Imiquimod does not have an adequate cure rate to treat as primary agent, we said, but it can be used to improve the cure rate after surgical excision. So treating with an additional therapy after primary therapy has been performed is termed adjuvant therapy. And you're going to hear about neoadjuvant therapy in a coming talk today, but adjuvant therapy is after you try to treat it primarily. So if you cut it out and you want to do something afterwards, like radiation afterwards, or treat it with topical medicine, that's called adjuvant therapy because it helps you increase the cure rate of the primary treatment that you used. So using Imiquimod around the excision site after an excision of melanoma is a form of adjuvant therapy. Adjuvant therapy of melanoma isn't used in a location where wide margins can be taken. Like I said, if you can be very confident in your margins, the margins are all clear, then you're not going to use Imiquimod as a mop-up. But if it's on the face, you want to take narrow margins, you're doing something like Mohs surgery, it's just really hard to read the slides to make sure you get it all out, then you want to consider something like Imiquimod around the edges of it to increase your cure rate. And I do this all the time. I just cut out a melanoma in situ of a person's neck on Thursday, 2 days ago, and I'm going to let it heal up. We let it heal up for about a month, and then he's going to start applying Imiquimod to the edges of the wound daily for 8 to 12 weeks, adjusting for tolerance. You have to adjust it back from daily because almost everyone would get very raw if they used it every day for a whole 8 weeks or something. So you basically cut back until it's just red, but not raw. And that's what he's going to be doing starting about a month from now. And it will increase his cure rate. So let's talk a little bit about the future here. We're going to talk about topical immunotherapy. So we talked about Imiquimod, that is a topical immunotherapy. Now let's talk about DPCP. Now this is for treating melanoma cutaneous metastasis. So this is a different type of melanoma. This is melanoma that's already spread to other parts of the body, and it's one of those parts of the body it can spread to is back to the skin. And that can be very troublesome. It can be functionally debilitating and cosmetically devastating. So we need treatments for this form of melanoma that's spread this way on the skin. So this is a gentleman. This is out of the journal. This is melanoma. And you can say, Dr. Linden, why did you let it get that bad? Well, he didn't let it get that bad. He had a small melanoma that was deep. And so that was cut out, but then it had already spread to other parts of the body. And one of the places it came back to is to the skin. So just like it can spread to the lungs, liver, it can come back to the skin. Well, this is very troublesome. So what they decided to do, you could radiate this whole area here, but that's a huge field of radiation. He's going to lose all his hair too. So what they did in this article is they used DPCP, which is like Aldara and Imiquimod. It's a topical agent. They put it on there and look at this is some weeks to months later, and you can see the melanoma is basically melting away. That's amazing. And a lot of this is probably just dead melanoma cells because even if you biopsy this, probably wouldn't show any live melanoma cells. It would just show pigment that was just being gradually eliminated. So you can have success stories with topical things like DPCP. This is another case. You can see the surgical scar up here. So this was cut out, looks like a couple of years ago. And usually within a couple of years, if it's going to do this, where you can see all these little dots, like ink dots here. These are all little metastases of melanoma where the melanoma has sent out little seeds out into the lymphatics here. And it's bad news. You can't cut out all this stuff. So you're going to either have to treat it with radiation or something else. Well, they use DPCP. And you can see this immune stimulating agent. It stimulated his immune system. You get this nice ripping reaction, just like you can to Imiquimod. But look, all these things have melted away. So that's amazing. Okay. Now, this case was, I'm going to be wrapping up here pretty soon. This case was one in our Journal American Academy of Dermatology, one of the two main derm journals. And it's a letter, and they report this patient had a bad melanoma. It was deeper than 2 millimeters to begin with. So unfortunately, it did spread, as it's highly likely to, and it spread to his lymph nodes and lungs. And he got 4 cycles of dacarbazine. For the oncologist in the room, that's going to bring back some nostalgia because we don't use dacarbazine much anymore. And probably not good nostalgia because it wasn't that effective back then. It was only about a 6% maybe complete cure rate or something, complete remission rate with it. So it's not a great therapy now that they have all these wonder drugs. But that didn't work. It didn't solve the problem. And the lung lesions and the lymph node lesions progressed. And they started giving DPCP to the skin lesions just to try and palliate it, to make those better because they were getting worse and worse and worse on the skin. And they did that, and they got some improvement with the skin. But then they basically they stopped that. But then about a month later, all these skin lesions and the lung lesions and the lymph node lesions started melting away, and he got into complete remission. He was in complete remission for 18 months at the time of this publication. So the DPCP, they postulate, stimulated the immune system, just like we have all these nice immune checkpoint inhibitors now, which I'm probably aware of or you'll hear about. And so it was working from the outside to stimulate the immune system rather than like the immune checkpoint inhibitors that we use now, where they're infused or taken by pill and so forth. So this is a great case and very exciting. So in summary, I've basically talked about topical agents that are FDA approved to treat skin cancer. And there are not that many that are FDA approved, like say Imiquimod, 5-fluorouracil. We use a lot of agents off-label. Imiquimod, you can use it as adjuvant treatment for melanoma in situ after it's cut out. DPCP can be used to treat cutaneous metastases. And basically, in conclusion, I want to say that topical agents are FDA approved to treat certain forms of skin cancer, and they can be useful off-label for treatments of some types of melanoma under certain circumstances. And so the keys are there, some types like in situ or melanoma metastases under certain circumstances. And usually it's not a first-line treatment for melanoma in any case. And I predict in the future that topical therapies will be more widely used in conjunction with immune checkpoint inhibitor therapies in treatment of melanoma and other cancers. There are people doing that now where the oncologists are working from the inside with the immune checkpoint inhibitors, and that's stimulating your immune system from the inside. And then if you put something like DPCP or Aldar on the outside, you're getting a double whammy. And some people are doing that, showing increased response rates. And so obviously we want to continue to do that. And so I think you're going to see more of this. I think it's an untapped area. So I think there's some excitement there. Lastly, Dr. Chao talked about our anti-cancer challenge. Here's our melanoma team at UCI. We're the melanoma magicians, and we're the melanoma magicians because we are making melanoma disappear. And so you're welcome to come and join us on October 11th. I'll be running. These are our walking contingent here. I always like to run it, but this is our whole team here. Thank you very much for listening to